Hypertrophic cardiomyopathy is primarily recognized as a disease of the sarcomere, the fundamental contractile unit of the cardiac muscle cell. It is the most common transitionally inherited cardiac disorder, typically following an autosomal dominant pattern. Majority of identifiable mutations in hypertrophic cardiomyopathy occur in genes encoding proteins of the thick and thin filaments of the sarcomere. Myosin binding protein C, cardiac, MYBPC3 mutations often lead to haploinsufficiency, where the cell doesn't produce enough functional protein, leading to gradual structural changes. Beta myosin heavy chain, MYH7, these are typically missense mutations where the mutant protein interferes with the function of the normal protein. Each of these have been identified in about 20% each of hypertrophic cardiomyopathy cases and higher number in larger families. TNNT2 cardiac troponin T. Notable because mutations here can sometimes cause mild hypertrophy but a high risk of sudden cardiac death. TNNI3 cardiac troponin I mutations, TPM1 alpha tropomyosin, ACTC1 alpha cardiac actin are all other cardiac sarcomeric genes. MYL2 and MYL3 myosin light chains. These mutations are uncommon causes of hypertrophic cardiomyopathy, together being responsible for less than 1% of the hypertrophic cardiomyopathy cases. The central paradox of hypertrophic cardiomyopathy at the molecular level is that the mutations often cause hypercontractility rather than weakness. The super relaxed state, SRX. Recent research highlights that many mutations, especially in MYBPC3 and MYH7, disrupt the super relaxed state of myosin. This unshackles the myosin heads, making them ready to bind to actin more frequently. Increased ATP consumption. Because more myosin heads are active, the heart consumes more energy, leading to a cellular energy crisis. Impaired relaxation. The excess cross-bridge formation prevents the muscle from relaxing fully, leading to the hallmark diastolic dysfunction seen in hypertrophic cardiomyopathy. Comprehensive testing identifies a causative mutation in roughly 30 to 60% of patients with a clear clinical phenotype of hypertrophic cardiomyopathy. Genotype negative HCM. Patients who meet clinical criteria but have no identifiable mutation often have a later onset and a lower risk of familial transmission. Phenocopies. Some genetic disorders mimic HCM but involve different pathways such as Danon disease, LAMP2, Fabry's disease, GLA, Friedreich's ataxia, FXN. The molecular understanding of HCM has led to the development of cardiac myosin inhibitors like mavacamten. These drugs specifically target the molecular defect by shifting myosin heads back into the super relaxed state, reducing the hypercontractility and relieving the outflow obstruction. The relationship between genotype and arrhythmogenesis is one of the most complex areas of HCM management. While hypertrophy itself creates a substrate for re-entry, the molecular defects often precede structural changes, suggesting a pro-arrhythmic state at the cellular level. The specific gene involved can significantly alter the electrophysiological profile and the risk of sudden cardiac death. Mutations in TNNT2 are classically associated with a high risk of sudden cardiac death despite only mild or even absent hypertrophy. This is a critical clinical red flag. These mutations often increase calcium sensitivity, which shortens the action potential duration and increases susceptibility to ventricular arrhythmias. MYH7 mutation patients often present earlier in life with more significant hypertrophy and a higher incidence of atrial fibrillation due to progressive left atrial remodeling. MYBPC3 mutation often associated with a later onset of symptoms, but once hypertrophy develops, the risk of ventricular tachycardia remains comparable to other variants. Current guidelines primarily use clinical markers for ICD placement, but genetics is increasingly being used to tip the scale. The multiple mutation effect. Approximately 5% of patients carry more than one mutations, compound or double heterozygous. These patients typically have a much more aggressive course and a higher threshold for early ICD consideration. Sarcomere positive versus sarcomere negative. Patients with an identifiable sarcomere mutation generally have a higher risk of SCD compared to those with genotype negative HCM, who often have a more benign clinical course. Non-sustained ventricular tachycardia. The frequency and duration of NSVT on Holter monitoring are more concerning in patients with high-risk mutations like TNNT2 or ACTC1. Research is shifting toward identifying pre-phenotypic markers in family members who are genotype positive but phenotype negative. ECG changes. Deep S waves in V2, V3 or T wave inversions can precede ventricular wall thickening. Mechanical dispersion. Using strain imaging to find subtle delays in contractions that correlate with future VTVF risk.